Thank you for joining us this evening for what we're calling Learn About the ABLE OA, a Schroeder Orthopaedic Advanced Therapeutics Center clinical trial. And we have joining us today Dr. Sowmya Viswanathan. And we also have Dr. Christopher Kim from UHN. I should introduce myself, Murray Downs, president of MD Biologics. And we just wanted to share some information about the trial to everyone, and specifically, go in more detail about the trial. Sowmya will, but Dr. Viswanathan will, but just give you a better idea of where we are with this trial and how we're looking at novel ways, therapeutic ways to treat osteoarthritis. And so we'll give it a few more minutes to allow some more people to jump in. And so we'll just hold on for another few minutes to allow a few more people to get in. And what I will do now is introduce Dr. Viswanathan and Dr. Kim. So Dr. Viswanathan is a scientist at the Osteoarthritis Program, Division of Orthopedic Surgery, Schroeder Arthritis Institute, and the Krembo Research Institute. Also an associate professor at the Institute of Biomedical Engineering and Department of Medicine, University of Toronto. She is also co-director of the Schroeder Arthritis Advanced Therapeutics Center. Her research is focused on developing novel cellular and immunotherapies to target osteoarthritis, including using proprietary enhanced mesenchymal stromal cells, MSCs, and reprogramming monocytes, macrophages using small molecules and gene-edited iPSCs. Dr. Viswanathan was the co-principal investigator of a Health Canada authorized clinical trial using autologous MSCs to treat osteoarthritis patients. It was a North American first, and is now leading another Health Canada authorized trial using autologous cellular therapies to treat osteoarthritis patients and using immune profiling to discriminate responders from non-responders. Dr. Christopher Kim, who is also co-PI. Christopher Kim is an orthopedic surgeon and assistant professor at the Toronto Western Hospital and scientist at the Schroeder Arthritis Institute, University Health Network. He obtained his MD at the University of Ottawa and orthopedic surgery residency at the University of Toronto. Following residency, Chris completed his lower extremity reconstruction fellowship at the Toronto Western Hospital and completed a PhD at the University of Toronto. His surgical practice focuses on robotic-assisted total knee replacements. His research focuses on basic science research, cell therapy, and engineering designer cells to prevent and treat osteoarthritis. So without further ado, just some housekeeping. There will be Q&A. The Q&A is turned on, so please, if you could, hold your questions till the end of Dr. Viswanathan's presentation. She has a brief slide deck that we want to go through, but we do encourage some questions about this clinical trial that is already underway. And without further ado, I'm going to kick it over to Dr. Viswanathan to talk about the clinical trial.
Thanks, Murray. And also, what a treat to hear my name pronounced right. I know you practiced. Okay. So I have a few slides, and I just wanted to talk to you a little bit about this. So I know a few weeks back, there was a webinar with Grant's work. So it's very similar in that we're using this intra-articular injection for autologous bone marrow aspirate, which is not processed in any way, but we're comparing it to a placebo injection. So this is really like a level 1 evidence trial that we're doing. So it's randomized, it's placebo controlled, it's double blinded. And I'll explain why we're doing this so very rigorously and what are the benefits of doing it this way. So a little bit different from the trial that you might have heard about a few weeks back. We're calling it ABLE OA. It actually has here we go. So, back in 2019, you could do some of these injections in Canada, but it started kind of getting a little bit of a bad name because it was advertised and sold really as a stem cell trial. And Health Canada was like, whoa, wait a minute, there's no authorized stem cell treatments for any musculoskeletal indications, and you only have to do this under the auspices of a clinical trial. So fast forward, post-COVID, right? We can only do this legally in Canada as an authorized trial because Health Canada considers this a drug. And because I think a lot of people are very interested in non-surgical options, and we really think that the way these cellular therapies work is because they have tons and tons of growth factors and cytokines, including things like IL-1 receptor antagonist. And these are made by a variety of cell types. We're actually not sure which cells make what, but we know that cocktail of factors that are produced are really helpful in repair, in helping reduce pain and improving function. So this is really the reason that we're doing this study. And it's really two studies under one kind of umbrella. So there's the bone marrow aspirate, and the second study is lipoaspirate, which is a little bit microionized. So this is not stromal vascular fraction, like we're not disintegrating it or enzymatically digesting it. It's still got its architecture. And then we're giving a PRP chaser along with that because we're not kind of disrupting that architecture. The bone marrow already has kind of the blood in it, so it doesn't need that. And the control arm for each is saline. Patients get a 9 ml injection, and whether they're randomized to the placebo, which is the saline arm, or the bone marrow arm, they all get a bone marrow aspiration. Same with the lipoaspirate. Everybody gets a lipoaspiration, whether they're randomized to the saline or the lipoaspirate arm. This is to maintain the blind. And so the clinician would not know it, and the patient would not know it either. Chris, did you want to jump in and maybe talk a little bit about the study design? I thought we could tag team a little bit here and go back and forth. I'll put you on the spot here if this one's okay.
So again, all patients will be randomized. Either one will, all of them will receive, the procedure of the bone marrow aspirate here specifically, which we've started now, or the lipoaspirate. And then they'll be randomized to either receive that or the saline control. So you can see here that the bone marrow aspirate will be, the standard procedure where the patient, will be prone and will be obtaining the bone marrow aspirate from the iliac crest at the back. And it's a 1-to-1, so it's a double-blinded randomized trial, and the duration is about a 6-month endpoint with a 1-year follow-up. And so what our sample size and the goal here is to have 84 patients, and this may change depending on an interim analysis report. And Sowmya and I can kind of chat about that if there's any questions about numbers and how we kind of got through that. But it was approved by Health Canada through strict analysis and seeing how many patients would be best in both arms. And so that was a number that we received. So really, this is truly, a Health Canada authorized, phase 2-3 trial. It's multi-centered, and it's a prospective double-blinded randomized placebo-controlled trial. It's adaptive, and this is going to allow us to really evaluate whether bone marrow aspirate in this part of the study that we've already started, it can be an injection for the treatment of knee osteoarthritis.
You want me to take that, or you want to take it?
Yeah, sure. Go ahead.
Okay. So I guess, and the sample size calculation is really based on kind of our primary endpoint. And the primary endpoint we decided to go with was the response rate in the NPRS score. So this 11-point scale from 0 to 10. And we thought our hypothesis is that people who receive the bone marrow will have 35% more greater response rates than the people who receive the placebo saline control. And we've called a response basically a 2-point increase in the NPRS score, because we know that 2 points is really clinically meaningful and helpful for the patients, obviously, depending on where they start on the baseline. We're taking patients who have NPRS 4 and greater. But we also have a number of secondary hypotheses, and I think this is one of the things that differentiates us from any study that's been done or to date or been published, right? So we're really trying to understand why some patients respond better than others. One hypothesis is because we think that baseline profile of these patients, like their immune profile, their inflammatory profile, really sets them up to be good responders or not good responders, right? Because these therapies, we know, produce a lot of anti-inflammatory factors and they interact a lot with the immune cells. So where the patient's baseline immune status is, where their BMI is, where some of these indicators are, and we have a bunch of biomarkers that we're using to kind of measure this and tease out this effect. And if we get additional funding, we also are collecting and biobanking all of the samples so we can do lots of omics type studies and analysis and get very sophisticated and apply sort of machine learning algorithms to really help us to tease out some of these profiles of responsive patients. The other kind of hypothesis that we're also looking at, and this has been done a little bit, but maybe not to the extent that we want to do, is, the bone marrow aspirate itself is going to be different from patient to patient, like the number of cells, the different types of cells, the different growth factors that are present in there. So again, if we could profile that, we can correlate, a good responder has XYZ profile in their composition, and maybe that'll help us set some standards for what a good composition should look like again down the road. So these are some of the metrics that we're trying to pull out from our trial, which I think separates us quite a bit from what's already been done and published in the field. And it's really very high quality level 1 evidence, which has been missing for some time. Chris, did you want to maybe go over the endpoints?
Yeah. So as Sowmya mentioned, we have, our primary endpoints, and then we have some kind of key secondary and exploratory endpoints. But our primary endpoint here is really to see whether this intra-articular injection of bone marrow aspirate versus saline in patients with knee osteoarthritis over the 6-month period. And so these patients, will be followed up to that point. And as she mentioned before, that we really want to see whether there's an improvement in pain. And this is, some greater than 2 points using the numerical pain rating scale at the 6 months after the injection. Our key secondary endpoints here include the improvement of the KOOS pain scale at 6-month post-injection, as well as improvements using, the activities of daily living at about 6-month post-injection. And some of the interesting kind of things about this study that will definitely, hopefully, really strengthen the study and really strengthen, the treatment option using bone marrow aspirate here versus saline, is that we're going to be looking at some exploratory endpoints, and these include the NPRS as well as the KOOS pain scores at 6 months, the KOOS ADL function scores at 6 months, and then, really looking at, the cellular composition of the bone marrow aspirate as well as the factors in there. As we mentioned, we're going to be taking them from multiple patients. There's going to be heterogeneity. We really want to know prior to injection, and if a patient responds, is there something that we're seeing in the composition of the BMA? And then we also want to look at kind of the local and systemic immune cells, inflammatory profiles of these patients. So we may get into this, but we are taking, baseline as well as when the patients do come back at 6 months. Not only are we going to, take their questionnaires and their KOOS pain and their activities of daily living, but we're also going to be taking, their blood. They are, giving a sample of their urine as well as getting their synovial fluid. So we can really look at kind of finding out, what systemic and what local changes they're seeing within, their blood and their urine and their synovial fluid, and be able to profile these patients and hopefully find out, whether a patient responded or they didn't respond, and if we can kind of figure out why that happened or not.
So just some inclusion-exclusion criteria. We are looking at, taking patients with a certain level of baseline pain. So we want patients with moderate pain. We've just amended this to include sort of bilateral OA. We didn't want to have a BMI greater than 30, although I do think we're thinking about this a little bit. And this was because we were going to do this protocol applies to both the lipoaspirate as well as the bone marrow aspirate. And we were worried with the lipoaspirate if we were going to get sort of more inflammatory fat in people who had a BMI greater than 30 when we're technically obese. There might be some metabolic dysfunction, and we didn't want to inject that into the knee. But I think we're thinking about this a little bit more and whether we need to be a little bit laxed on this for the bone marrow aspirate study where this is less important. We are sort of treating moderate OA, so the Kale grade 2 and 3. We've excluded 1 and 4, so we're kind of in the middle. And then sort of the usual things that we're excluding, including not having surgery or having had any kind of injections within the last 6 weeks, and we want them to be at least off NSAIDs for the duration of the study, and kind of note any medications that they're taking. Yeah, again, I think we've got about six visits. I think only 2 of these, the procedure visit and the 6-month visit, needs to be in person. Everything else can be done online. So it's a lot of questionnaires. And there is a bunch of questionnaires that we're collecting from these patients. We're collecting blood, urine, synovial fluid. We're biobanking all of this because, again, this is going to be a very data-rich study to help us really dissect some of the mechanisms. I didn't want to spend too much time on it. And then the randomization, right? This is really so we can reduce bias. And because we know that there is this huge placebo effect, we want to be very, very, very careful about how we're doing this. So we've got all kinds of protocols to maintain the blind, and we're stratifying the patients based on their Kale grade or their NPS scores. And then we can, again, post-hoc stratify them based on kind of sex and other attributes. So we can really understand what's happening with some of this, with this kind of rigorous methodology. Chris, back to you.
I mean, you can't do any of these things without a huge team. Just like Grant mentioned, I know he has, himself, but also other people supporting him. So very similar. We have a whole team here. Obviously, Sowmya and I are presenting, but really behind the scenes, we have a wonderful team here. So we have Osmosis Research, who's been really, is a CRO who has been really supporting us and helping us kind of through this clinical trial. But we have a bunch of other research technicians, Ida, Rachel, Anu, Shobha, Rania, as well as Bree, who've been instrumental in the beginning. We've enrolled up to, we've done about 7 patients now so far. And none of this would have been possible without the team. And obviously, we also want to thank not only UHN, Schroeder Arthritis Institute, but MD Biologics for really just providing support with their product, and as well as Osmosis Research as well too.
Yeah, and just to add, MD Biologics has been kind of helping us from the beginning, right? Like even when we were planning the clinical trials and we were going back to Health Canada had a bunch of queries, and we'll talk a little bit about this, but we had some setbacks and we had to change kind of we had to change vendors. So, MD Biologics really helped support us and get letters and other things that we needed to kind of get this approved by both Health Canada and also by our institution's ethics board. So I think we've been in this for a while, so really excited to finally be up and running and enrolling patients, as you'll see. The other thing is, as Chris said, we really need a village, and we're trying to create this network of referrals, right? So a lot of this is kind of in the Toronto region, and working with Ultim Health and other sort of allied professionals, but also with kind of walk-in clinics and private clinics and sports medicine clinics, other hospitals. We're really trying to get the word out. The study is still fairly new, as you can tell, but we need tons of referrals, especially if we want to get to the numbers that we talked about. So 84 is sort of one target, but really we might be looking at, a couple of hundreds by the time we're all said and done. So we do need this network of referrals. And I just wanted to take maybe the last 2-3 slides to tell you why this trial is so very important, right? Because if we want to get this therapy approved again in Canada, unfortunately, we're going to have to go through this drug pathway that Health Canada has created. And we've had some talks with them about the Schedule G and maybe putting it in there, but they really want to see data, and not just any data, but rigorous data that's done in a controlled setting. So a controlled randomized clinical trial, that's the level of evidence that we need to show in terms of proving efficacy because of the placebo effect and because of other effects, right? So, and they're very happy with our study design. And if the results are positive, then, they would consider the evidence from this trial as kind of pivotal evidence. And really, in order to do a randomized trial where you're not charging because you don't want to charge patients for getting saline, you need a public institution like ours to be able to undertake such an RCT. But the goal is to get the evidence, to get the market authorization, and then to really make this widely available to Canadians. So this will not just impact kind of our center, but all centers that want to be able to offer this as a treatment. And right now it's sort of a let's try and see approach, right? Like you may have failed PRP, you may have failed a few things, and then you kind of go through that laundry list of let's try this, right? And we wanted to change that approach a little bit, and this is why we're collecting all of this blood and urine and synovial fluid and doing all of this profiling at the cellular, biological, and molecular levels to help us maybe identify categories of patients who respond or who respond better, right? And so we can really personalize and customize treatment and maybe try to stratify patients that we think are going to be good responders to this type of therapies and anti-inflammatory therapies in general. So we're asking you to kind of help us and join us because we need this kind of evidence for approval, and we need you to send your patients to us and refer your patients to us, right? So first of all, they don't pay, so everything is covered. This is a fully covered trial, so they don't pay for any of this treatment. They may be randomized though to the saline arm versus the treatment arm, and we don't have a control over that. It's a 50% shot, but the wait is only 6 months, right? So we're not asking a very long period of having to wait. And it gets them into UHN. They get tons of follow-up visits, all this questionnaires, all this very close follow-up and care that they'll be getting. And of course, they'll be contributing potentially to this future treatment if the results are positive. And we've tried to make the referral as easy as we can, right? So we don't need you to do any of the screening. If you think the patient's kind of falls in that moderate OA stage and has moderate pain, then just send them to us. We have posters, we have postcards, we're working on a short video, we have a 1-800 number, we have an email. We're listed on clinicaltrials.gov, so we can provide all of this material to you. Just send them to us, and then we can do the screening. We can, Chris will review the X-rays, like we'll review the eligibility and see if this makes sense. That's really all I had for sharing here. Chris, I don't know if you wanted to maybe jump in, but in terms of slides, this is all I had. So I thought the rest of the time we could spend kind of talking and discussing this. I'm going to stop sharing so we can see each other.
Okay. All right. Great, Sowmya. Thank you. So it doesn't look like we have any questions. So I'm just going to start off with a few questions. And Sowmya, you mentioned I know about the first clinical trial you did using bone marrow aspirate. Is there any correlation between that study and this study? And a follow-up to that would be, what made you get into this? What made UHN get into this space, and what made you get into this particular treatment option?
Yeah, I mean, so we've actually done so why we got into this, maybe I'll answer that first. We've done kind of a knee osteoarthritis trial that was also Health Canada authorized. So this was taking mesenchymal stromal cells from patients, again, from their bone marrow, but then culture expanding them and growing them up in a GMP, which is good manufacturing practice facility, and doing all of the release criteria, quality, and all of that, right? And even when we were doing that, there was, the surgeons were like, why don't we just put the bone marrow? Why don't we just put the bone marrow? Because we don't really know what's causing the effect, right? And if it's a stromal cell population or if it's another population that's really causing the effect. And it's very time consuming and very expensive. And at the end of the day, maybe the benefits are not that much greater, right? So this interest in that was there for some time. And so we've been kind of it's been brewing, but then we got some philanthropic funding for this, and we decided to do this, and then to do it really in a big way, right? Like to do a powered study, to really be able to answer some biological questions which kind of have not been answered and and are plaguing the field. So that was our motivation. I did see there's a question about the lipoaspirate on the Q&A, Murray. I don't know if you want maybe me or maybe
yeah, go ahead. Yeah.
Chris, did you want to take that one? It's about adding PRP and lipoaspirate, and if there's a co-intervention bias in that. We add both. But I don't think it works if you just add the lipoaspirate, right?
Yeah.
At least the lipoaspirate, the way we're calling it a lipoaspirate. So just to be very clear, like it's just fat, right? Like it's not even digested. Like the matrix is all there. Like like the cells are all in that structure. So like they're not really activated or able to do anything, we think, without the PRP, and this has been shown. So it's almost not active without the PRP is how I understand it. But Chris, maybe you can explain that better.
Yeah, and it seems like that's through our literature review and when we've chatted with people who are doing this, it seems like you need to activate it with the PRP. So even Grant Pagden is doing that, where PRP is given into everything. So we felt that we should align ourselves with kind of what the standard is and what people who are interested in orthobiologics or these types of injections, especially in the knee. I mean, if you're manipulating it more or you're doing more to the fat, maybe that would be different. But here, especially when we're just taking the fat and then adding the PRP in there, the decision was made that this would probably be the best way or kind of the standard of care in regards to these orthobiologics.
Great,
So
thank
Chris,
you.
Yeah, go ahead, Murray.
You want to follow up? Sowmya?
No, but I saw this question from Frank on the chat about the
Okay.
meniscal.
I'm just going to bring it up.
Yeah, because we kind of went back and forth on that, Murray, with you as well, right? So
yeah. Have you got that question, Chris?
Yeah, I can see that. So definitely, if someone, I would say majority of our patients do come in, unfortunately, with an MRI. So many of them do have X-rays where we can grade, the KL grade there. And then many of them, because they have knee pain, obviously, then they will definitely come and have an MRI. So do all patients need an MRI? No. So another thing is obviously a clinical examination. So I will assess them, or we'll have our kind of co-investigators, co-applicants kind of assess the patients. If they do have a meniscus tear, we have basically deemed it that a meniscus tear in the setting of arthritis, as you're saying it, like a KL grade 3, most likely they would have a degenerative tear. So what we're saying is that if on X-ray they're not a KL grade 1 or a KL grade 4, they're obviously they're excluded. If you're going to be included in this study, you have a KL grade 2 or 3, based on radiographic X-rays, and then the clinical exam is key. So if you have an MRI, obviously we'll look at the MRI. But if you had any history of an ACL tear, any other kind of ligamentous issues, and then obviously if you have signs, say for like a bucket handle meniscus tear or something where you're stating that you have a blocked extension or a blocked flexion or something that doesn't deem from osteoarthritis, those patients will be excluded. So we've actually included patients where they may have a meniscus tear in the setting of degenerative osteoarthritis, a KL grade 3 or 2. And then we also obviously chatted with other kind of studies that have been out there on PRP and NSTRIDE and HA and corticosteroid. And we didn't really see, in talking to some of these investigators, we didn't see that they had any exclusion for people who had meniscus tears, other than something like a bucket handle meniscus tear, that could be clinically appreciated, or an ACL tear. And so we basically are including these studies. And the one thought we had was that if we take away anyone who has a meniscus tear, you're not going to have any patients, right? So very tough to find a patient who is, KL grade 2 or 3 with no meniscal tear, which obviously it would be very impossible to find. So
yeah, the point was not to exclude them, right? We just needed to be very clear on like certain kind of bucket handle tears. So that is not an exclusion criteria. So, but you're right, we did need to clarify that.
Just a couple of questions also to follow up on the patient's time to go in for the bone marrow aspirate procedure. I mean, from showing up at the clinic, Chris, you might want to, how long is a patient, how much time are they giving up to come and have the procedure done? And is it painful?
Yeah, that's a great question, Murray. So patients are not, it's not taking that long of a time. The patients are coming, obviously they're meeting the team. If there are any kind of last questions, any questionnaires, it probably takes about 5 to 10 minutes to go through that. Many of these questionnaires are done prior to that. At that time, we have basically 2 rooms. One room is where the procedure is taking place, and the other room is for processing. The patient will come, the patient will change, and then basically, at that time, one of our, clinical researchers will come, obtain blood, and then basically obtain a sample of their urine. And then right after that, you have myself and 2 other kind of orthopedic surgeons who are trained in this procedure come, and then we start the procedure. The procedure probably takes about 10 minutes or so, and then the patients are are put prone. The procedure's done. Then they're put back on their back, and then we begin basically the injection. And then in the synovial fluid aspiration. We do obviously use lidocaine for freezing. It's usually like a 1% lidocaine. And then we obviously use a calculator to measure, how much lidocaine they can use. We've done about 7 now, and patients have on the next day, no one has really complained of any issues. Many of them have, taken Tylenol and iced it, but we haven't had any kind of adverse events or effects or anything like that we've seen in regards to the procedure as of now. So
Okay. And just to
But I would
follow
say
up to that. Go ahead,
beginning to
Sowmya.
end, maybe 45 minutes, an hour tops, right? Like
Yeah,
we're
yeah.
it's not very onerous, so
It's not a
we've
long
kind of
time.
got it down really. Yeah.
Okay. A follow-up to that, what would be the period of time that a patient would need to forego additional treatment if they're enrolled in the placebo group?
6 months is what we're asking, right? Because we don't really, we can't, that's our endpoint is 6 months. So, if it's not working, it takes at least 3 months, right, before they can see anything. So really, we're asking for that 3 months. So it's not a very unreasonable ask that we're asking them to wait for a long period of time. And again, it's a 50% shot, so we think this is a good deal. Yeah.
Yeah. Okay. And we do have a follow-up from Frank just saying, what's your hypothesis on the profile?
Yeah, great question, Frank. So, I mean, well, I'm very interested in studying monocyte macrophages, and we've shown that there's a specific class of them. We've actually published on this. Maybe I'll put it up on the chat, but we've shown that patients that have an increased frequency of this have worse kind of pain symptoms, WOMAC stiffness, etc. So, we wanted to see if there was a difference in that kind of the monocyte macrophages, but also T cells. We've seen some interesting correlations there. So. We're studying a bunch of different subsets because we don't really know which ones are doing that, but main focus is, I would say, monocyte macrophages and T cells, and having this specific class at higher frequency might give them worse pain, but I don't know if that makes them better or worse responders, right? Like that's the unanswered question. Like if they start off worse, then is it because they were so bad they have an improvement, or if they start off worse, is it, okay, they're already worse, nothing's gonna kind of improve them. So, there's a few different theories that we have. The immune profile is one of them, but the other one is also kind of pain and sensitization. So we're measuring pain, trying to use other instruments as well, right? Like questionnaires to see if there's certain patients that maybe won't respond like no matter what, and certain patients that will respond no matter what. So they might actually respond to the placebo treatment as well. So very interesting data. So hopefully we'll be able to answer some of this, and we're going to need a larger sample size than 84, right? The 84 is per study, by the way, it's not for both, but even that 84 is probably not enough, which is why the trial is designed as an adaptive trial design. So we can have a look at the data. It'll get unblinded in between. We can take a look and see like what the effect is in the treatment versus the placebo. This is done by an arm's length external data monitoring committee. Like we don't do this. So it goes to this external, very experienced, very senior data monitoring committee that has done tons of clinical trials, including spirifermin and others, right? Like, so the real OA experts. So they're going to take a hard look at the data and make recommendations about, increasing sample size or what we need to do statistically. So we went through kind of 3 rounds of meetings with the Office of Biostatistics with Health Canada as well to like really come up with this adaptive trial design. And we wanted to start with a number that was feasible, but I do think we're going to have to go larger, which is why we're asking for your help with referrals and to send patients down to Chris to do the study.
Okay. We got a couple of questions here from Maimuna. How are you addressing the co-intervention bias of lipoaspirate with PRP in the study too?
It's already answered. Thank you. I just have one last.
Oh, okay.
Will there be any test done on the PRP to see its actual, in actual sense, was it the lipoaspirate or the PRP that gave the result?
Yeah, I mean, it's a combined therapy. So we don't have a PRP alone group, right, to tease out that effect size. The PRP we're giving is kind of a 2 ml injection compared to a 9 ml lipoaspirate. So I just want to make that clear. So it's not really like a full dose of a PRP injection or treatment. But we are going to be biobanking the PRP and kind of looking at the growth factors that are made by that, the platelet-derived growth factor and other things that are secreted, again, because there'll be differences from patient A versus patient B in terms of the PRP composition and growth factors that are produced. So we are going to be looking at that and trying to correlate that back to efficacy in terms of response. So we'll be doing that. And as part of doing that, I guess if we see a signal that correlates more with the PRP than with the lipoaspirate composition, that'll help us indirectly answer the question which you're asking, which is it the PRP or is it the lipoaspirate? We can't do it directly, but I think with that analysis, we'll be able to indirectly answer that if we have a good enough sample size.
Thank you.
Good. Well, we got one follow-up question from Frank here. Is it also possible to count the platelets used? For example, 2 ml with lots of platelets or 2 ml with few?
Yeah, and we had to do that kind of for our release. So yes, we're doing a whole bunch of metrics, right? So we are going to be counting. Like we looked at all kinds of things to count, and I think the platelet count was one of them. So that'll be something that we are going to be looking at. And even in the bone marrow aspirate, right? Like just total nucleated cell counts, like there's some evidence there that you need a certain number of that. So there's a bunch of things we're counting and measuring for sure, so that we'll have some answers to that. But we wanted to go beyond just counts, right? Like we wanted to get a little bit more in depth. So, but yes, you're right. We are doing that.
Okay. We got some follow-up questions from Dr. Nathan Thacker. I think cost of treatment is already answered. There's no cost to the patient. If a patient is enrolled in the saline group, will there be an option for them to switch at some later date to the treatment arm?
Yeah.
And I think that's been answered.
Yeah, too difficult to do a crossover trial. Like you need you need 1,000, like a very large, like statistically it gets very messy. I think the compromise that we talked about this, right? And like if we were doing like a 1-year follow-up or something like that, or even longer, then maybe that crossover would have made sense. But with a 6-month, we thought that was a reasonable period, but no crossover. So yeah. But if it gets approved, then this can be a real treatment for others, right?
Well, I think that's why you mentioned it's it's adaptive, and that's the whole goal is to get more and more numbers, the better. More numbers, the better, for sure. Is there a summary sheet for referral and the components of the trial? I think you already shared with that, Sowmya. So I guess maybe even if you could do it at the end of the program, or maybe put it up so we can see that at the end. And then one more question: can you discuss the merits of age on MSC activity?
Yeah, I mean, so first I want to caveat this by saying it's not an MSC trial, which is mesenchymal stromal cells, right? Like we're not isolating them, we're not expanding them. In bone marrow, it's a very small population, and I don't know if it's necessarily the most important population, right? So IL-1 receptor antagonists could be made by endothelial cells or hematopoietic cells. Having said that, we know the frequency does diminish with increasing age. This has been shown repeatedly, right? So it could could be, it could be, and it will be going down, but I'm not sure that that's really the most important factor in this. So I actually think it's IL-1 receptor antagonist levels and maybe other factors that are secreted. It's this cocktail, but that's something we'll have to prove with our trials. So yes, the MSC content will be going down and the frequency will be going down, but I don't know if that's the most important factor.
Mm. Okay. One more question from Desanka. How important is BMI in determining a patient's candidacy for the study? I guess we're talking about the lipoaspirate study. If a person is overweight, obese, would you require them to lose weight first? I guess to both studies.
Yeah, I mean, so far we've had one patient that was slightly over 30 and very motivated, and they're like, yeah, come back when we lose weight. So right now it is an exclusion criteria, but we're taking a second hard look at that, right? We just had a meeting with our data monitoring committee, and they're like, God, you're going to be excluding an awful lot of people, right? With that, do you really need to have that? And we thought about it, and again, the protocol was written as a bucket protocol for both studies. So it was written because we didn't want to have this very inflamed fat that we were injecting back into painful knees, right? Like, so that was really out of abundance of safety concern. We're like, okay, let's not do that. But for bone marrow, I don't know that we are that worried about it, right? And so maybe we should broaden that. So one suggestion was to go to 40, right? Like, so we're still kind of in that range, but 40 BMI would give us some patients, with like real world kind of statistics and demographics of having the OA, and I don't think would affect our trial. So we are looking at that right now, and we can amend that. So that's something we're considering, especially given that we want this very large N sample size. This might be one of the ways to go.
And it's surprising to see that we haven't really seen anyone, other than that one patient, of the 20 or so that we've had and we looked at, majority of them were BMI under 30, right? And so whether it's a selected population or whether it's because we're looking at KL grades 2 and 3, hard to know whether it's because of obesity and the metabolic syndrome and OA and all the risk factors. It's hard to say. But there's only been that one, and then that patient, had to, was on their way of losing weight anyways, and then has been deemed eligible right after losing that. So, but again, we are, as Sowmya was mentioning, we are looking at that and seeing if we should change the BMI to 40 or so.
Okay. Well, I guess Sowmya, thank you very much, and Chris for joining us, and everyone for taking the time out of your evening to go through this presentation and webinar. If there's not any more questions, I guess, Sowmya, if you could share again how the physicians can refer patients. I will also say that we have William, who is with MD Biologics, Territory Manager for Ontario, can also share some information. And if you want to get in touch with William, your rep, I think we are confining it to Ontario, if I'm not mistaken, Sowmya.
Yeah, I think, there is that visit 1 and the visit 3, which is a 6-month visit in person. The other ones can be done online, but we just thought for patient traveling, that might make sense. But if there are people that are fully motivated and can make that commitment, that's okay. The poster and postcard is available. We're going to be revamping this so we can provide tons of this to MD Biologics and William to distribute. We also have this 1-800 number. We have an email. So if you see a patient that you think might be interested, we'll of course give you the posters and the postcards, and we're also kind of putting like a little short 30-second video together, so that's going to be coming soon. But they can call us, they can get in touch with us, we'll do the screening, and we can kind of take over. So we don't want to put a big burden on you, but we really want to get the word out to the clinics and to the patients. I think that the people that we're seeing in the hospital are coming, I would say, more surgical candidates, right? So we need to get the patients that are a little bit earlier, are interested in non-surgical interventions, which is, I think, a big reason why we wanted to reach out to you and to your colleagues to help us get this right patient population, which maybe we're not always seeing at the hospital setting. Yeah.
Yeah, there is that gap. There is the gap that, typically our customers are seeing those patients at that, not necessarily end stage, but are looking for some options to, beyond PRP, beyond the traditional methods of visco supplementation. So
Yeah.
I think it's awesome. As you know, before 2019, a lot of our customers are doing both lipoaspirate and bone marrow aspirate procedures daily.
Yeah.
And, until, Health Canada decided to take this turn. So we're doing our best to get the word out. So I think thank you, William, for just sharing your contact information there. It's on the chat, and feel free to reach out to William or myself if you want any further information. But on that note, thank you very much, everyone, for joining us, and thank you for taking the time.
Thanks, Murray.
Thanks, everyone.
For joining.
Thanks, everyone.
Appreciate you on a Monday
Bye,
night.
Sowmya. Yeah,
Bye.
you're welcome.
Thanks, guys.
Take care now.